I wanted to introduce the day of talking about data and later about finance by telling a story. And this is really kind of just in a way just to set the stage. And then in 3 or 4 minutes, I'm going to have the privilege of introducing Karen Larson, who's our new CEO at the Steinberg Institute. But let me start off by reflecting on something that really impressed me as I was going through a long career in mental illness. And it has nothing to do with mental illness. It's actually a story that comes out of the world of oncology. When I was a medical student, the last thing you wanted to do was to rotate on the pediatric oncology ward, because in the 1970s, and even in the 1980s, most of what you saw were kids with acute lymphoblastic leukemia, ALL. It's the most common cancer of childhood, at least 6,000 cases a year. And in those days, it was 90% fatal. Today, it's 90% cured. And that happened over about 3 decades. When I was at the NIH, I got interested in this problem, and I went to the director of the Heart, Lung, and Blood Institute, who was then a very brilliant woman named Dr. Susan Shuren, who actually was an expert on ALL. And I asked her, what was the breakthrough? How did you go from 90% fatal to 90% cured? Because we need some of that. I thought that would be interesting to know for the world of child mental health. And she said, it's the wrong question. She said, there never was a breakthrough. There wasn't a new drug. There wasn't a new diagnostic. There wasn't a molecular marker. There wasn't a new intervention. She said that what happened for kids with acute lymphoblastic leukemia was that we changed the way we cared for them. She said, it wasn't a breakthrough. It was a slow but continual process of learning how to do better. So I said, well, how'd that happen? And she said, it wasn't complicated. What we did was we essentially established centers of excellence, and we ensured that every child who had ALL became essentially a research subject, a research volunteer. We learned from every kid. And it wasn't a question of sort of like moving from research to practice. We moved from practice to research. We made our approach to acute lymphoblastic leukemia based on a learning engine that we were constantly collecting data and constantly learning from that to know how to do better. And what we discovered was how to combine treatments, how to continue treatments, how to improve nursing care, essentially how to give better care to get better results. And slowly, it wasn't one thing, but slowly putting those pieces together as we learned how to do this better, we in fact did get better results. It went from 90% fatal to 70%, 50%. And ultimately, as we learned how to continue treatments for months instead of for weeks, how to combine different medications and different aspects of nutrition and other things that they ended up doing, we got to the point where we are today. And I thought that was a really important story for us to hear, because too often in the world of mental health, there's this idea that there's going to be some magic bullet, that if we could just find the right biomarker or the right drug or the right psychological intervention, that will solve this set of very complicated problems. And I think what you can learn from that pediatric oncology story is that it begins with data. It begins by collecting information on everybody in a way that helps you to learn as you go. It's building this learning engine, which we've failed to do here. Now, there are attempts to do it. So for first episode psychosis, we have the EpiNet effort. What EpiNet starts with is creating common data elements so that every young person with a first episode of psychosis will have the same sort of data collected in the same way. It will filter into the same database and will create, kind of like with ALL, we'll create a national database that begins to be the foundation for that learning engine. There are other ways to do this, other places to do this. I'm not sure that first episode psychosis has to be unique, but it's where we've started. And I think it does give us the beginning of a process that can ultimately fundamentally change outcomes. So that's my parable for the Thursday morning of Breaking Barriers. Let me turn this over to Karen Larson, who I'm just so proud to have as a colleague at the Steinberg Institute, who's coming from a long period of service as the Director of Health Services at Yolo County, and now is bringing all of that expertise to help us think about what we can do in the state of California. Karen, floor is yours.
So I'm Karen Larson. I'm the new CEO of the Steinberg Institute. I've been there all of 6 weeks, so bear with me as I go through the slides. Hi, Toby. Such an honor to have the day kicked off by Dr. Insel. He's one of our board members at the Steinberg Institute and just an inspiration. He didn't plug his book, but he has a brand new book out if you're interested. And we have highlighted it on this side. The amazing thing about this book that Dr. Insel came out with is that it focuses much more on folks having a person, a place, and a purpose than anything to do with his medical degrees. So it really focuses on getting away from the medical model and leaning in when it comes to treating behavioral health conditions into those kinds of things that mean the most to the people we serve. I'll do a quick overview of the Steinberg Institute and me personally. The Steinberg Institute was founded back in 2015 when now Mayor Darrell Steinberg was leaving the assembly. He had termed out and realized that there wasn't in the legislature, there wasn't a lot of advocacy around mental health conditions. And he was worried about losing that momentum that he had started with MHSA. And so he started this institute. Well, now, I think you all know, we're in a very different place. I think there's over 200 behavioral health bills coming out of the legislature today. So, fast forward 7 years and pretty amazing things have happened. We'd love to take credit for some portion of that, but I really think the pandemic helped more than anything in the last couple years. In addition to the work we do in the legislative space, we also work to convene partners. I think we're one of the rare organizations that's an independent voice, right? We don't have, the funding we get doesn't have ties to it. We don't have a board of supervisors telling us what we can or can't advocate for. And so all of the things we advocate for at the Institute are really for what's best for the people who we focus on. Generally speaking, we focus on the folks who don't have a voice, people who are uninsured or underinsured in the Medi-Cal system. But for example, our parity bill really focused on everyone and having equal access and equal focus on mental health and substance use disorders as we do on physical health. So I'm going to move on. I'm going to talk a little bit about data for a few slides. Hopefully you can all stay awake. Hopefully you've all had your coffee. I will say that several of the slides are not uplifting. They're depressing, to say the least. But I promise to end with a little rah-rah at the end, and it won't be quite as depressing. So what we know about our kids and youth and how they're functioning, or how they have been functioning over the past few years, it's not great. When you look to Children Now does an annual update. If you look at the report card, our scorecard for mental health for our children and youth gives us a D+. So that's not great. And California has so much opportunity above and beyond other states, so relatively disappointing. We are 43rd out of all of the states in the United States in terms of spending on children and youth behavioral health. So this is not great, but it's about to change. So just, spoiler alert, things are getting better. I will say this slide represents data from before the pandemic. So things were already bad before the pandemic hit, and they didn't get any better. This is a slide that shows there's a survey that's done with children and youth, generally in the K-12 environment, where they ask about mental wellness, and you rank it on a score of 1 to 10. If 10 is rainbows and sunshine, everything's great. So pre-pandemic, 68% of kids ranked their mental wellness at 7 or above on that scale. And as we hit the pandemic, that dropped dramatically, down to 39% ranking their mental wellness at 7 or above on that 10-point scale. I think one of the most important things as we talk about data and look at data and outcomes, one of the most important things that can come out of that is as we start to dig a little more deeply and parse out disparities. And we have populations within California and throughout the United States that are disproportionately impacted by system involvement and bear the burden of these outcomes more than others. And so this slide the picture on the left shows you our suicide rates. You'll notice that the trend line for suicides hasn't really changed that much, that it's stayed generally static over the past several years. But if you look at I think it's purple for you guys. If you look at the spikes, that's for our Black and African American children here. So you'll see that it's spiked. It's more than doubled in the past few years. And so that has everything to do with poverty, systemic racism, and the pandemic and the disproportionate impacts on those communities. So it would be easy to say, oh, our suicide rates are pretty static, right? We're doing okay, at least they didn't get worse. But the reality is we have to dig deeper into our data, look at our communities who are having disproportionate impacts, and find ways to intervene and fix the trend. And then on the right-hand side, another community that's disproportionately impacted are LGBTQ youth. While only about 14%, which is still a super high number, of our heterosexual students, children and youth have contemplated suicide, nearly half of our LGBTQ children and youth have. And so we have to, again, look deeper at our data and find our special interventions for those populations who are disproportionately impacted. I find this slide interesting. I don't think of California as a rural state. We have a lot of urban areas. But I will say many of our counties are considered rural in nature. We have, especially up north, if you think of, our Plumas County, but, Inyo, Mono, there's all these little counties who are, during the winter completely shut off from being able to access services and whatnot. And what we know is that for our children and youth in rural areas, they have, again, trouble accessing services, trouble with stigma, maybe more so than we do in more urban areas. And this stat on the right actually comes out of the CDC and shows that the rate of suicide among rural youth, the 15 and 19-year-olds, is 54% higher than that of their counterparts. And it's increased dramatically over the past 12 years by over 74%. So again, digging deeper into the data, looking at those communities where we need special attention and evidence-based practices to affect positive change. This is another slide that talks about substance use disorders. I think it's easy to forget to talk about substance use disorders when we're talking about mental health. They are both brain health matters, and I think we all know that fentanyl has dramatically increased overdose rates in the state of California and throughout our communities. Again, this is happening maybe more so in some of our rural communities, but it's really everywhere. And so this just shows the dramatic spike in drug overdose for our children and youth over the past several years. You'll notice that this spike, or this trend, stops in 2020. And so we all know that over the past 2 years, that number's only gonna grow and get bigger. I'm done with most of the depressing slides, so we can all take a collective breath. I think as much as I nerd out a little bit on the data and those macro level data pieces and like how do we address those as a state, I think it's really important for us to remember that there are these individual children and youth at the center of all of our systems that are struggling. And everybody in this room has one kid or youth that they carry around with them that they were able to, that touched their heart. And maybe that child or youth has even come back to you as an adult and said, like, thank you so much for what you did to me. You changed my life. You were my only person. You know, we all have that. And I think it's important to carry that little person with us when we do our work, because it's very easy for us to stay in our bubbles on this slide and think about, like, I know my bubble and I know what I can do to affect change, and it's kind of hard to reach across to other bubbles and to share maybe what we don't do well, our data, our outcomes, and to partner together around those data and around the outcomes and improve and focus on ways we can share resources and information to improve the lives of our little people. I often tell the story that I came from Yolo County. I was the Health and Human Services Agency Director there, and so we had all things public health, mental health, behavioral health under my watch, which was amazing. And I talk about the county, I often call it the Goldilocks County. Not too big, not too small, just the right size. And over the course of my tenure there, we were able to work across systems to really improve outcomes for our children and youth. We went from, when I landed there in 2014, the investment in children's mental health was around $2 million. And by the time I left a few months ago, it was over $10 million. So little for some of you who come from San Diego, LA, Orange County, but a dramatic increase over the course of that time. And it wasn't just from Health and Human Services. There were, you know, we had resources coming from the state and grants, and we were able to leverage all of these funding sources to draw down additional federal revenue. And because we had shared outcomes and this kind of collective impact model, we were kind of all driving in the same direction. We agreed upon these are the things that will improve the lives of our children. Is it perfect? Nope. I totally believe and embrace the concept of continuous quality improvement. You get a little better each day. You maybe pick a data point and realize it's not really the best data point, and maybe we should pick something else. So, but it's important to share the table and make sure that table includes your community, not just the systems, right? Like, you have to include the parents, the family members, and the children and youth. So I love this little face. So I think that this is how we believe that outcomes and accountability can come into play, especially in this moment in time we're living through. We have a bill currently, it's mostly focused on the Mental Health Services Act, but it's to create a statewide dashboard whereby all the counties, yay! It's up for hearing next week if anybody wants to watch. The concept is that there would be this community health needs assessment involving everyone. They would kind of look at the data available and choose the metrics they want to focus on. And then once those metrics are chosen, have a system improvement plan to address the needs. And that there'd be a publicly facing dashboard for every county throughout the state of California where folks could see how they were doing on these trends. So all of those, that bill was built around all of these concepts, right? Like, have some outcomes that everybody agrees on that you're gonna focus in on, because it's easy to get distracted if you have too many. Have accountability by having a publicly facing dashboard, especially for things that are funded by taxpayers' dollars. Have this focus on continuous quality improvement. It doesn't have to be perfect. It doesn't have to be from the start 100%, right? You can start with small chunks and move along. And make sure, again, that you're involving the community and not doing it without them. So our funding in California is complicated for behavioral health. These are all of the funding streams, and this is before we have this big initiative that's rolling out from our governor, but there are local sources of funds, there are health systems funds, there's regional centered funds, there's these things called IGTs, which seem a lot like money laundering, but they're really legit, you're really able to do this thing where you get more money for things you did. So it's pretty complicated. They don't always braid though, right? And so braiding funding streams across public systems, especially for our children and youth, really does drive better outcomes and really drives for a broader impact. That slide a few back where I talked about us being 43rd in the nation in terms of behavioral health spending, a huge part of that has to do with Medicaid or Medi-Cal. For every dollar we put in to a behavioral health service, we can get an additional dollar back from the federal government. We don't do the best job with that. Here in California, we could do much better. And that includes monies from other children serving entities like the school districts, like the cities, like whoever you have contributing, as long as it's an allowable source of funds, you can draw down additional federal revenue. And whenever possible, right, we want that money from the feds to come to California. So as if that wasn't complicated enough, a bunch of new money is coming. So it's a pretty amazing opportunity. I think most of you are probably tracking, and I think you actually had a few talks here about the Child and Youth Behavioral Health Initiative coming out of the state. I have talked about this. It couldn't have come at a better time, you know, having just lived through this pandemic with our kids. And it couldn't have come at a worse time. I think our workforce in the behavioral health space is pretty decimated, and I think this Child and Youth Behavioral Health Initiative, by all accounts, is going to take some time to set up, and our children and youth need it now. But it's a beautiful vision, and I think between the Child and Youth Behavioral Health Initiative, the things within the CalAIM initiative that will help our children and youth, and the federal resources flowing down through ARP and some of the other sources, we really have so much funding available to us at this moment in time. If we could figure out our path to braiding those funding streams and really working together to maximize those federal funds coming down and whatnot, we really have the opportunity to serve every child and youth in our school settings, in our preschool settings, in our post-K-12 settings. And I think, you know, I talked about our behavioral health workforce, but I know all of our other workforces are suffering. We're all struggling with retention and burnout, and so asking all of our systems to come together at this moment in time and really dig in and do this hard work of sharing data, sharing outcomes, figuring out what the outcomes are we can all agree on, and then sharing the financing, which is probably the biggest challenge from my personal experience. It really, it's a big challenge. It's a hard time for everyone, and it's the most important time, I think, for our young people. You know, those stats at the beginning, some of them are a couple years out of date and are only going to get worse. And what I think we've seen actually coming out of the kind of public health emergency is that that some of our children and youth are actually having more substantial mental health issues on the back end, like reintegrating, for lack of a better word, back in with their peers and whatnot. So I think this is my last slide, and it kind of says what I said a moment ago. I think this is your call to action. This is all to your leaders, to your electeds. This is the moment in time. We will never have another moment in time like we have right now to improve the behavioral health of our children and youth in California. The next governor will not make child and youth behavioral health his priority because it's this governor's priority. And so we have a little bit of time to get through this and to sort it out together. And I hope that we can take advantage of this moment in time and work together to share the data, share the outcomes, and share the financing so that every child and youth in California can get the services they need and become successful members of society and not struggle for the rest of their lives through a variety of other system involvement. I think I often share this story, and I'll share it just as a close. I worked in Yolo County for 23 years, so I worked in community clinic for a very long time before I joined the county, and I worked there long enough that I had little people that I met when I first came to the county. They came to a child development program with their moms. Their moms were in substance abuse treatment, and the little people would come to the child development program that was attached. And so we babysat kids. I'd be in my office holding babies, and I worked in Yolo County long enough that I watched those babies grow up and enter my juvenile justice system. And then I watched those babies, because they were kind of stayed my babies, grow up a little more and enter my adult criminal justice system. And then I watched them grow up a little more and have babies of their own who entered my child welfare system as I became the director over that. And that's a failure. We all fail when those things happen. I saw them living outdoors as adults. I went to more funerals than I'd like to mention. And that's what we're talking about. Whether you're in a little place like Yolo or a bigger place, we've all had those types of experiences, and that's what we have the opportunity to change. That's where we have the opportunity to work together to really change the course, the life course of our most vulnerable children and youth. And so I'm done. Thank you for having me this morning.